Red man syndrome is an occasional complication of vancomycin infusion. Previously, it was described as an anaphylactoid reaction. Currently, in literature, it is described as non-IgE immunologic anaphylaxis reaction. The symptoms may be mild in its presentation or severe to the point of life-threatening in condition. The signs may occur as early as 4 to 10 minutes after starting of infusion, and this can be precipitated by an infusion rate of less than 1 hour in duration. Red man syndrome or the red neck syndrome manifests as hypotension, cutaneous flushing, erythema, urticaria, pruritus, and maculopapular rash, primarily of the face, neck, arms, and the chest. This unusual feature of vancomycin is due to its ability to nearly double the histamine release from basophils and the cutaneous mast cells through a poorly understood dose-dependent mechanism. When we give the vancomycin infusion of 1 gram in less than 1 hour duration, then there is increased chance for development of this red man syndrome. Although it may be clinically indistinguishable from the anaphylaxis in the operating room, diagnosis relies primarily on the exclusion of other intraoperative events that may produce hypotension, the temporal relationship of cardiovascular instability to vancomycin infusion, and the observation of other manifestations of a histamine release such as periorbital, periocular, or the facial edema, bronchospasm that is due to stimulation of bronchial histamine receptors, hypoxia secondary to histamine-induced inhibitions of hypoxic pulmonary vasoconstriction, and subsequent formation of pulmonary shunt. Attention should be given to other histamine-inducing drugs that may potentiate the symptoms of red man syndrome. Tryptase is the marker for immunologic mast cell activation. In vancomycin-induced anaphylactoid reaction, tryptase release does not occur. Assays for histamine release are usually impractical because histamine concentration peak 5 minutes after the onset and return to baseline within an hour after release. The liberated histamine causes dilation of peripheral blood vessels and simultaneously increase in cardiac output, stroke volume, and pulmonary arterial blood pressure. However, the peripheral vascular dilation is the most prominent physiological feature and may induce severe hypotension and cardiovascular collapse. Management options include the following: discontinue or slow the infusion rate of vancomycin, administration of the bolus intravenous fluid, discontinue or decrease the concentration of the other agents that are capable of inducing hypotension, like the anesthetic drugs or sodium nitroprusside, administered H1 antihistaminics like the diphenhydramine, considered inhaled beta agonist if bronchospasm is present, administer vasopressor like the ephedrine, phenylephrine, or epinephrine for severe hypotension, initiate advanced cardiac life support maneuver in case of cardiac arrest. Prevention of red man syndrome. The concentration of vancomycin should be less than equals to 5 mg per ml and the rate should be less than 10 mg per minute. For example, 1 gram of vancomycin should be diluted in the 200 ml of NS or 5% dextrose, and this to be run over more than 100 minutes. Pre-medication with the diphenhydramine 50 mg orally 1 hour before the infusion may also prevent this syndrome.